Well, hello everyone. This is Chadi Alraies from Heart Trending. I'm really privileged today to be with one of the late breaker trials and great science that was presented at ESC Congress in London in 2024. As we know, the DAPT and monotherapy for after ACS PCI has been a big topic and more research evolving. So I'm really privileged today to be with Dr. Valgimigli, who presented a Ticagrelor monotherapy or DAPT after drug-eluting coronary intervention in patient with or without ACS, a patient-level meta-analysis randomized control trial. Marco, thank you so much for being with us.
Thank you very much for having me.
So tell us a little bit about the background of the study and what is the hypothesis?
We put together an individual patient data meta-analysis by clustering all available RCTs, comparing monotherapy with Ticagrelor versus continuation of dual antiplatelet therapy up to 1 year after PCI, with or without ACS, acute coronary syndrome. We found 6 studies. We were able to gather the database of all 6 studies, and we ended up having a final patient population of roughly 25,000 patients who underwent PCI. And then from 2 weeks up to 3 months after PCI, either continued the DAPT or implemented a Ticagrelor monotherapy approach until 12 months. The study was powered enough to assess the non-inferiority hypothesis of monotherapy versus dual antiplatelet therapy. And then, of course, if met, we plan to go ahead and test superiority in the whole population, as well as specifically in patients with ACS.
A very interesting and very practical topic. As we know, there's population, high bleeding risk population that can benefit the most, or people who are really increased risk of bleeding. So a great number of population, 25,000. This is phenomenal. As you say, you can have a lot of subgroup analysis from it. So let's walk us through the main findings of the result of the study.
So we pre-specified as a primary endpoint the so-called MACE, major adverse cardiac and cerebrovascular events. It's basically composite of CV death, myocardial infarction, stroke. And with that respect, we saw a pooled hazard ratio of 0.91, slightly numerically in favor of monotherapy, with an upper limit of the 95% confidence interval of 107. We pre-specified a 1.15 non-inferiority margin, which actually preserves 50% of the treatment effect of aspirin versus no aspirin in prior MI patients, as per historic studies. Therefore, the non-inferiority was highly met with a highly significant p-value. So that allows us to go ahead and test the superiority for bleeding, which was also met, was a roughly 50% risk reduction of major bleeding complication in favor of monotherapy. And finally, we also pre-specified to test as in a hierarchical manner as a third co-primary endpoint, all-cause death, which was also significantly reduced in favor of monotherapy. So I think the data now, it's pretty much conclusive, at least the way I see them, also because we ran what we called trial sequential analysis. Namely, we ask the question whether the data would be prone to change if new study were conducted in the future. And now we have a clear-cut answer. The answer is no for the non-inferiority of MACE. The answer is no for superiority and bleeding. These are pretty much definitive findings. Whether there is some room for further investigating mortality, because the mortality benefit was not deemed to be conclusive, meaning that we would be very happy to have further studies addressing this outstanding issue.
Hugely, congratulations! That's phenomenal findings, and going to be as a new things that will be a great additive to the guideline. How long do you think this is going to be taking? As you know, meta-analysis is considered kind of the father of all studies because you are including all randomized trial, and now you have a strong evidence as you mentioned to us with a significant statistical value. When do you think this is going to take effect into our guidelines?
So it's difficult to tell. And of course, as known member of the guidelines, of course, you also have to be caution in over-interpreting your own findings, because of course, other people will have the job to do so. However, I think the recommendation will reverse, Now, recommendation is class 1A DAPT, with some opening for monotherapy after few weeks or few months in selected patient populations. I think, to be fair with the data, the future and upcoming guidelines should do the opposite. They should give a class 1A to monotherapy, perhaps with some residual dual antiplatelet therapy beyond a few weeks or few months only in selected patients. Having said that, the data do not suggest that there is any specific patient subset in whom there is clear benefit from dual antiplatelet therapy. Actually, the lack of benefit of DAPT is pretty much consistent throughout all pre-specified subgroups, including high-risk patient subgroup, complex PCI, acute coronary syndrome, STEMI, non-STEMI, left main stenting. So at this stage, I would not be able to tell you which patient should be better off on DAPT than monotherapy.
Yeah, I know. And as you said, the findings are really strong. So if you wanna speak to a very cautious or very conservative interventional cardiologist, and I know your findings was very strong for monotherapy, which patient selection, let's say the left main, the proximal LAD, that you would think, you know what, maybe should be a DAPT population before we go to monotherapy, or do you have a different or a small vessel for ACS? For PCI?
So first of all, I would like to clarify that in the monotherapy arm, there was some degree of dual antiplatelet therapy to begin with. So the monotherapy is not from the get-go. That is very important. For the time being, the minimum duration should be 2 weeks, and in 2 studies up to 3 months. Which DAPT phase should be preferred, either short, 2 weeks, or slightly longer. It's completely unclear. We have done sub-analysis and the data are entirely consistent. Therefore, our data set cannot suggest which initial DAPT phase to go for. My approach is actually 1 month. That's what I do. And I am honestly not very concerned about left main stenting or complex PCI. I am embracing that treatment since years. And now we have strong data to support that approach already. So I don't think that the fact that you are making a complex PCI should justify prolonging DPT beyond a few weeks or few months, honestly speaking. Of course, if you have a very high risk young individual, perhaps with recurrent acute coronary syndrome, in whom the bleeding risk is very low, I would say that trying to protect even more that patient with a DAPT regimen instead of monotherapy may make sense. That probably is the only patient in whom I would think doing so. Another point I would like to clarify is that I was speaking about monotherapy, but in fact our study is Ticagrelor specific. We know that if you would embrace clopidogrel instead of Ticagrelor, the results would not be the same. We know it because we have done previous studies showing that clopidogrel is actually inferior to a DPT regimen. And unfortunately, we have to acknowledge that we don't have data for prasugrel. So monotherapy, of course, seems to be the way to go, but be careful because the type of monotherapy also matters.
Yeah, that was my next question. Can we extrapolate ticagrelor to clopidogrel or prasugrel? I think it's hard to.
And this so clopidogrel, no. We have the data that is published in JAMA Cardiology a few months ago, and the data are clearly showing that ticagrelor is one animal, clopidogrel is another one. With prasugrel, we don't have data. Probably I would be prone to believe that the data would be reproducible with prasugrel because prasugrel is a potent and reliable P2Y12 inhibitor. But again, that's an estimated guess, not based on evidence.
Well, this is definitely a very enlightening findings, Marco, and congratulations for you and your team for publishing the finding as well as presenting it at ESC Congress 2024. I'm really privileged to be with you. I really thank you for all your time, and hopefully we see more coming from your lab in the near future.
Thank you very much. A wonderful day to everybody.
Thank you so much. Have a nice day.